Hello, my name is Seth Griffin. I practice anesthesia in Northern California, and with this recent COVID scare, I've been tasked with creating a manifold system to ventilate more than one patient. I've got two different types of circuits on here. One is a standard circuit from our respiratory department, that's the blue circuit, and one is our anesthesia circuit. And I just wanted to demonstrate that they're both functioning. It was really quite easy to build. I had a series of T-pieces and connectors that I went and got from the respiratory department. There's lots of configurations you can put this in. This is the configuration that I found works best for our vent in our situation. You could also adjust this to make it a T on the top or the bottom or whatever. So you could set it up in this configuration if you were using 2 circuits, or you could set it up like this if you were using 3 circuits. Similar to a respiratory therapy vent, we have our filter, our viral bacterial filter, on the proximal end of our circuits, not only to protect the patients, but providers as well, and any backflow of air that may occur in this system. On the distal end of the system, I have a HEPA filter, which goes into the machine, hopefully keeping the machine clean. Like I said, there's quite a number of flaws with this system. You first have to have patients that are about the same size, lung volume, airway resistance, and other similar factors. We do expect these patients to come in and go into ARDS, so this is not going to be for our end-term ARDS patients, but more of our interim, because obviously we won't be able to differentiate our pressures or our volumes, and we don't want one patient with stiff lungs shunting air to another patient. Vent pressure, these vents are often run on our 50 psi oxygen pressure from the wall. So if you're running a lot of these vents and a lot of ventilators throughout the building, throughout the hospital, you could reach a capacity issue. We have a change in my soda sorb, okay? Our soda sorb, if it gets expired, will create high carbon monoxide levels. We want to try and avoid that. What we've done is we've gotten an old container that does not have any soda sorb to block off this system again. So if we can do that, that's what I'd recommend, so we don't have carbon monoxide contamination. And remember, we would also want to run high flows up on our monitors. There's a variety of configurations that you can set this up at depending on how many patients you're ventilating, what your equipment is, and where you want your filters, your HEPA filters and other filters. There is an issue with spontaneous breathing patients and where they may be breathing dysynchronously. The use of paralytics may come into play here. I would recommend individually ventilating patients and pulling various recruitment maneuvers and evaluating each patient's lung status individually while you're using this system. There was a paper published in 2006 by Dr. Neiman and Dr. Babcock of Detroit listing some of the limitations and workings of this system that we're trying to put together here. And of course, Dr. Babcock has a great video on YouTube that you all should watch as well. There was also a study done in 2008 where Dr. Palladino attempted to ventilate 4 sheep for 12 hours on this system. He did so successfully, but did reveal some real oxygenation and ventilation issues while doing so. In response to the coronavirus, various people are trying to come up with fixes for these downfalls in this system. Dr. Mergue of Belgium came up with a simple system of using basically stopcocks purchased at your local hardware store to put in line. So I've tried to mimic that here with some success. So I went down to my local hardware store and got some PVC piping designed for water, and I fit it together and used a little tape so that it fits snugly into my system. What I've been able to do by doing this is effectively decrease flow to what I would consider a good set of lungs and shunt that flow away to a more damaged set of lungs. So as you can see, I've installed this homemade stopcock system into the inspiratory portion of our vent. As you can see on the other side, there is a one-way valve. This is very important for this system to function. As I partially close off this stopcock, you can see that the lungs are inflating at different rates. So decreasing this flow also changes the IE ratio on this, what we would call a good lung. The PEEP and peak pressures should be the same depending on what your set IE ratio is and your respiratory rate. Here I just wanted to show that there was a one-way valve installed in the circuit. I was also successfully able to apply this multi-circuit system to the Marquet servo that we use in our Women and Children department. However, it did not work on the Hamilton G5 due to the inline sensor. This obviously is not an ideal solution and not for long-term ventilation. I hope none of you have to use this. But if you need to, here it is. Godspeed.